Good morning, everyone, and I'd firstly like to open the meeting by thanking actually Wokingham Borough Council for the use of this wonderful space, so thank you, Wokingham. First, a few announcements and updates to the board for supporting personnel. So I think the most exciting thing and the most positive thing is the announcement and the appointment of Nick Broughton as Chief Executive of Bob ICB. I hope you'll join me in congratulating Nick on his permanent appointment. It's a real benefit to us that he's been in the role for over a year now. He knows Bob inside out, its challenges, its strengths, and we look forward to continuing to work with him over the next few months and years. And I guess at the end of the day, the focus is to deliver better health outcomes for our residents and our communities, and under his stewardship and leadership, we hope to achieve this. I would like to welcome Claire Dobell. Claire is Deputy Director of Governance, and she's been with us for a year already, but following Catherine Mountford's retirement, so we just welcome very much Claire to step in, and the executive responsibility for governance will currently sit with Nick. Interim Secretariat support is provided by Ross Kenrick at the end there and going forwards, but I'd like to thank Aman Qureshi, who has left Bob for pastures new, but who attended and supported all of the board meetings over the last 2 years and was also co-chair of the Disability Staff Network. So I'd like to thank him very much for his contribution and for his support to this board and to me personally. Sad to announce that this would likely be the last board for which we're joined by Rachel Decoe, our Chief Medical Officer and Deputy Chief Executive, who'll be leaving us to join Thames Valley Hospice as CEO. I'll say a bit more about that later on, if I may. Matthew Tate today will be covering with Helen the Berkshire West Place update with Sarah Webster, our Place Director, who's currently on maternity leave. So Matthew and Helen will replace Sarah there. So apologies this morning. We've got an apology from Rachel Shimon, our partner member, representing local authorities, and we've got a few late entrants. I think Tim Nolan, non-exec director, and Margaret Batty, non-exec director, who are suffering with train issues at the moment, but they'll be here shortly. Can I remind everyone, this is a meeting in public. It's not a public meeting. The event is being live streamed. And for those tuned in virtually, the tech is set up so that you can observe only. And we have one member of the exec ICB team who's also online this morning. So if we can welcome Alistair Groom, who's joining us virtually today. If I could ask anyone who speaks to unmute their mic and then mute it when they've finished, and to allow people at home to follow, please could you say your name and who you are, and then that way everybody knows who's talking before the contribution. Just moving ahead then, I think we need to move on to the minutes of the meeting, is that right? Last held on the 16th of July, which seems like a lifetime ago. But if I could ask, please, for members of this board who were at that meeting to please approve the minutes or bring up any matters of accuracy. Take silence as assent. Yes, thank you, Claire. We can sign the minutes off. And from an action point of view, we've got one live action, one closed, and with details in the log. And updates are marked in red, which in this instance, update colleagues on a link. You can join the capital plan and the completed action. And just note the change of executive ownership for the governance review. Excellent, thank you. Declarations of interest, always complicated at an ICB, but the current register is attached for information, and all members have to declare if there are any interest in the agenda items. And where these are known, these have already been included on the front sheet of papers with an outline of how these will be managed. So the nature of our board, as you know, with partner members means there are inherent interests because of the organisations they lead or are part of. So for example, item 7, the chair's report, Item 8, Chief Executive and Director's Report. Item 10, Berkshire West Place Update. Item 11, Performance and Quality Update, the report for month 3. And the last item 12, the Finance Report. Other than the item 13, the reports are there for assurance or discussion, not decision. So the level of conflict is manageable, we feel, and as the perspective of all members is important, all may participate in the discussion. Formality over. So item 13 is seeking approval of proposed and highlighted changes to ease for our constitution, and also support of an application to NHS England for variation of that constitution. So we'll go through that in item 13. We have had 2 questions from the public, and that has come in advance of the meeting, which is what we ask. And one regards the strategic approach to service user involvement and the patient voice and experience function. Because this doesn't relate specifically today to the board agenda, we will publish the answer in full online within 20 working days following this board meeting. The second question is in relation to the change programme and operating model from our Health Watch partners, and that comes jointly from Oxfordshire and Buckinghamshire. And we'll endeavour to answer that through Nick's portion during his update of the CEO and Director's report. That concludes the official business, and I'm very pleased to be able to move on. Nick?
Just very quickly, Sim, at the last board meeting we received a question from the public in relation to the letter concerning our annual assessment by NHS England and whether we would publish that letter. It is included in today's board pack.
Brilliant. Thank you, Nick, for that update. Very good. We move on now to something very important, I think, for this board. And that is to welcome a story from one of our residents. And today we're welcoming Gloria Matthews. Welcome, Gloria. And Gloria's a SEND service user. So, and what we get is an experience, a direct experience from a user, and Gloria's a parent of a child who requires SEND services. So she's going to share her story with us, and she's supported by Miranda Walcott, a member of our nursing and quality team, and by Rachel Corsair, our Chief Nursing Officer. So Rachel, I'll leave it to you to give some context and to explain a little about why you asked Gloria to come today.
Thank you, Chair, and good morning, everybody. As the Chair's already said, my name is Rachel and I'm the Chief Nursing Officer here at the ICB, and it is with enormous pleasure that I'm here to hear from Gloria and Miranda this morning as we hear a little bit more about Elijah, Gloria's son. But just before I bring Gloria in, and Gloria's asked me to ask her some questions to help prompt the debate and the discussion this morning. But just before I do that, I just thought it'd be helpful just to remind colleagues in the board of where we are in our SEND and that special educational needs and disabilities journey. Members of the board will know this isn't something that's new. We've been talking about this in fact, probably at every board meeting, the importance that we place on supporting our children and young people, their families and their carers through their SEND journey. And as you know, it is front and centre of the BOBs of our ICB's Joint Forward Plan, particularly signposted in the Start Well area of that. As we sit here today in Wokingham, I think we are intimately involved with our colleagues in the local authority on developing the improvements around the SEND journey, and are delighted that our colleagues from Department of Education and the Care Quality Commission are acknowledging and noting those improvements in our SEND journey. And I think with that, it's important to hear Gloria's experience. And you'll see in the paper a link to the annual report that our colleagues from the SEND Voices Wokingham Partnership have just published, which again highlights some of the improvements that have been noted by families, parents and carers within Wokingham, but also signals some of the work that we're yet to do and still need to do, and remain relentlessly focused on those areas that we need to continue to improve. So I'm going to come to Gloria. And Gloria, please tell us a little bit about Elijah and what matters to him and to you.
Hi, my name's Gloria and I'm Elijah's mum. Right, so Elijah is a 20-year-old young man. From the age of probably about 4 months, he was diagnosed with epilepsy, but that also caused global development delay, so he's non-verbal. He requires 24-hour help. Yeah, incontinence as well, double. And also, even like when he was just younger, it was the case of not knowing how the outcome will be. They said that he would never walk, but he does walk now. But it's like he's walks like he's had a few drinks, bit unbalanced. But yeah, he's different. He's different in a good way. He's very different in a good way. But obviously, it was the seizures that caused all the delays in him. Non-verbal. He used to have about 50 to 60 seizures a day, and we just took it from there. It ended up in the hospital. Then we had to go to Oxford. Then he got diagnosed with his condition. But it has been challenging, but also at the same time, we've had good support as well. We've had good, positive support.
So Gloria, just tell us a little bit about how you've navigated your way through the SEND journey with Elijah, and perhaps just pull out for us 3 things that went really well and things that now, looking back in hindsight, if you'd have known differently at the time, what would have made your experience of care and the SEND pathway easier earlier on?
Right, the positive feedback I could give about the SEND is when Elijah had to start education, there was a couple of schools I looked at, but in my mind I just had Brookfield School, and he started that at the age of 3.5, I think it was, and from then he started off in a wheelchair, and through the school encouraging him, he had a walker and stuff, he progressed into not using his wheelchair anymore. So that was like really positive, and like even his achievements from the school has been really positive all the way right through until he's 19. It was just, I had nothing but praise for the school, and I really wish that after that journey from his school, there would have been a college or something as an adult could go to just to mimic that, because that part was a bit difficult. Oh, the health-wise as well, that has been positive, as in the wheelchair service has been excellent. No issues with that at all. Like when he needs his new wheelchair, it was breaking quite often because he's quite a strong lad. So they was always able to have somebody coming out 24 hours to get that fixed, because if it didn't get fixed, it means he wouldn't be able to go to school, or he wouldn't be able to go in respite. So that was positive as well. They had another positive impact as well, is when he needed a special bed. That was a really godsend, because he wasn't able to sleep in a normal bed because he didn't have the understanding of falling out or stuff like that. So that was another really positive impact in having that bed. Up until about a year now, I think it's a year, he's in a normal bed now, which maybe I could have probably done that sooner. I wish I had done that sooner, because he would have been able to access more things instead of just being at home or going to respite where they had the same bed. So that's one thing I wish I had probably done a lot earlier.
It's a hospital type bed that he's got now, isn't it?
Yes, yeah, the bed he's got now is the hospital bed. I can't remember the name of it, but it's got all the mechanical stuff where it could come up and down. So that is good. I'm glad it's done now, and I probably think it happened because he ended up in hospital last year because he broke his leg. And then the hospital was really, really good, as in getting a package, having carers, which I've never had before, because I've just always done it on my own. Having carers coming in now, a hoist and everything. That package was really done really, really well, and I'm like really grateful. And I still actually have the carers still now, which is really, really helpful, because even for myself, I just had, not long ago, had a knee replacement, so they were able to come in and look after Elijah as well. So that's positive for me, you know, that's positive.
And Gloria, one of the things that we spoke about when we caught up last week was your experience of navigating the transition. So we know Elijah's 20, and we've talked here before about the transitions work that we're doing, and we'll bring back through to board some of the work we're doing around our community of practice for transition. But just share with us some of the your experience of going through that transition from Elijah being a child into now becoming an adult, and how you're being supported through that process, and what more could we do to help you?
I thought the transitioning was quite difficult, actually, as in from a child into adult. I find that very difficult, not really knowing which way to turn or who to turn to, and not really having that support like you got when he was a child. I see it as like, yes, he was a child and now he's an adult, but his needs are still the same. And I find like I've gone backwards, as in, it feels like I have to start again, because I'm not getting that support. I'm not understanding the support or who to contact for the support I need for him. Getting him to where he is now, that wasn't like too bad, because we got the college I wanted him to go to. But then it seems like you're not getting that support you had when he was a child, but his needs are still exactly the same as an adult. And that's the piece I don't understand. And I'm not getting that support.
So you've had a lot of support, you've had a lot of support when he was a child from the medical teams, and then he went into adulthood and had to go to the GP for appointments. And how has that affected you, and what's that experience been like?
Right, so going to the GP, if I could avoid it, I will. I just can't do it anymore. The GP expects me to bring him in, which I've done when he was younger and smaller, but the access to the GP is not great. Yes, they've got the part where the wheelchair could go, but you're pulling a 20-year-old on gravel, and I've got to pull him in backwards. And I can't do it. I just cannot do it anymore. I get frustrated. Elijah's probably having a whale of a time thinking it's funny. And I just find it exhausting, because I've got to pull him in backwards. And by the time I get him backwards, the stairs to the GP is dropped down there. And I'm thinking, I can't do this anymore. I don't want to go bring him in with all that stress for a 5-minute appointment just to see how he's doing. So now I just avoid bringing him into the GP, because I just find that really hard work. I don't see the support there. It's not working. It's not working. Bringing him to the hospital is another issue, because I don't know what it is, but he's just got this thing about now. He just doesn't want to go in. He's grabbing. He's this, he's that. He had to have an X-ray not long ago. I left that for quite a while. And that's just a fight. It's a fight. It's almost like, I'm not going to blame it to do with the hospital. It's just that it just doesn't work. It just doesn't work, as in bringing him to the hospital or his appointments. Some of the appointments are not in Reading, and I just find it really stressful to be taking him to these appointments out of Reading, even in Reading. I just don't find, it's just harder. I don't know why it's harder, but it is harder as he is an adult, and I thought it would have been getting easier. I feel I've gone backwards, and I don't know who to contact for support. I just think you're just left in limbo, because he's an adult.
And is that education, health and social care you felt you've been left in limbo and having to keep telling the story?
Yeah, it's the whole picture. It's the whole picture of explaining everything from the beginning up till now. So it was just everything, just haven't got that support. No social worker. Well, I have got a social worker now, which I had to keep telling them, I haven't got one. Why haven't I got one? Who do I contact when I need help? You know, he's got issues going on with the college at the moment. So that alone is another worry, as in, well, what's going to be happening? Do I explain about that? Right. So I had an email the other day saying that they have no funding for Elijah at the college, so he shouldn't be going to college. That was sent on the second day when it started back in September. And I just didn't understand where that come from. It's like, well, why, if they didn't have that funding for him, why wasn't I told June or July before, you know, he's now gone back to college, and then they sent an email saying, you know, there's no funding. That's confusing. So now we have to work out where he's going to be going. So that's another battle. And I just don't find all this now, as I said to Miranda, I just can't do it. You know, I've got to this 20, he's 20, and it feels as though I've gone right back.
And Gloria, thank you. I think, you know, what we've heard is a real mix of your experiences, and as you start to navigate Elijah becoming an adult and moving into adulthood, that some of those pathways aren't as easy to navigate through as perhaps they were when he was a child. And we're hearing that loud and clear, and I think we'll take that on board. And as I've shared with Paul previously, we are doing work on that transition to get children from 18 to 25, recognising one of the things that we love about SEND particularly is that it means we have to work really closely with our partners in local authority. So that commitment across the partnership is absolutely there. And I know with the voluntary and care sector as well is an area that we work really closely with. Gloria, Elijah sounds like such a character and somebody that I can see brings so much joy to you and those that meet him. So thank you for coming today and sharing your experiences, the good and the less easy to navigate. We really appreciate it. And Miranda, thank you as well for coming and supporting Gloria. I don't know, Chair, if there's anything you want to add.
Just to say thank you, Gloria. It's always difficult, isn't it, to describe your journey, but sometimes it's good to reflect on what you've been through. You sound like an incredible mum, and we're just so grateful that you shared that with us. I just wonder if anyone else would like to ask Gloria anything or say anything at this stage. Nick?
Gloria, thank you so much for that. Do you receive any support?
No.
In an ideal world, would you like some support to help with some of these practical issues that you described so powerfully?
Yes, I would like the support. I would just like that guidance of what I should be helping to do, because I actually have no clue. It just feels like I don't know, I just feel quite bad actually that I've got to 20 years. It's not to say, you know, it's just been a year, 20 years, and it's like I ain't got a clue. I haven't got a clue what I'm supposed to do in. What am I supposed to be doing with Elijah? Who do I turn to? You know what I mean? I don't know who I should turn to get that support for myself, because I've never really I've had the support from out, as in like family and friends, right? But like within the whole system, I don't think I've had that support as much, or I don't know, unless I've missed it, but I just haven't had that support. I don't think I've had the support, or maybe because I didn't put myself out to look for the support. I just cracked on and just did it myself. And I think that's what a lot of people say. They go, oh, how haven't you had that support? Or why didn't you use the carers before? I just got on with it for myself until when something, you know, drastic has happened, then I've had the support. So I know it's out there, but I just didn't know how to access that support and who to turn to get that help.
Aidan. did you want to ask something?
Well, I did. I really just want to say thank you, Gloria, for such a powerful presentation to us. It's really interesting to hear some of the good things that happen. It's equally interesting to hear some of the frustrations as well. I think they're really valuable. And one of the things that really resonated with me, because I've been through not similar, but my mother had dementia, and you kind of, you know, when you're trying to deal with different parts of the state, and that bit's not talking to that bit, and that bit, and you feel like you're kind of just looking at this wall, don't you? This mountain of bureaucracy almost. But what really strikes me about it is it's more about culture than it is necessarily about resource. It's about people connecting, you know, different parts of the kind of state, if you like, connecting together in order to provide a service, rather than, you know, often is the response, we need more money, we need more money. So it's really valuable to hear the way you've described some of your experiences. But the one thing I really wanted to say more than anything else is, what an amazing person. You know, just thank you so much for talking as you've talked to us. And I'm sure you do know this, but I just want you to know what a fantastic person you are, brilliant and really awe-inspiring and great to hear.
Oh, thank you very much. I don't know if I came across correct or everything I really wanted to say. I don't know. I don't know if I did. I just think, I don't know. I think I could have done better, but...
Can I say Gloria is not alone in how she is as a parent. This is representative across the board, where we have parents like Gloria, parents like Gloria who carrying on and don't always ask for help and use the support network they have around because they can't get the support from statutory bodies to help them.
Thank you. Thank you both. And thank you, Rachel, for bringing Gloria to our attention. Thank you. Right, moving on with our agenda, I think it now comes down to me, the Chair's report. Now, I'm not going to dwell on my report. I just want to bring out a couple of things. Just to highlight, if you don't mind. So I think the first thing I'd like to start with is something joyous, which is the ICB is delighted to congratulate all of our system partners and colleagues who've been selected as finalists for the 2024 HSJ Awards. So, you know, we've been recognised as finalists under the following award categories, and they're all there listed. I just think it's really important to dwell on some positives as we move through challenging times. So, and I just want to congratulate those that have been nominated. Very strong. Another important piece of news is the ICP and the development of the Integrated Care Partnership. And as you know, that's a statutory body, and we've had a hiatus at the moment because of the election period. And what I'm very happy to announce is that we've had nominations for a new chair and deputy chair, and those nominees will be voted in at the next meeting. So most importantly though, work is underway to refresh and reset the conditions around the ICP. So I'm very happy to say that Rob Bowen, our Deputy Director of Strategy and Partnerships for the ICB, will be managing the ICP administration and secretariat going forwards. And that follows the retirement of Catherine Mountford, the former Director of Governance. So I just want to thank Catherine for her help with setting that up, and also to thank Jason Brock, who is the former Reading Council leader and chair of the ICP. So what we're doing is talking to the stakeholders, working out how the reset should sit and what we should do, focusing on a few pieces of work, but doing those very well. So that's very important. The other thing I would just like to mention is the recent riots in July and August, obviously shocking to everyone. But the reason I bring it up here is I just want to thank all of the trusts and our partners who put out messages of support to all of our staff, and to make it clear that we don't tolerate racism in any of our establishments. But I also, just from an internal point of view, want to thank the chairs of the staff networks at the ICB who came together and really supported our staff internally at a time that was quite frightening. And I think it's really important how we all came together and worked together for that. So I won't go on. I'm going to pass on to Nick now, who has quite a long report and lots of business to get through. But I'm happy to take any questions or any reflections on anything in my report before we move on. No? Excellent. Okay, so Nick, handing over to you.
Sim, thank you. And good morning, everyone. And just for those online, I'm Nick Broughton, the Chief Executive of the ICB. Can I just begin with something that's not actually covered in my report, and that's the publication last week of the report carried out by Lord Darcy in his independent investigation into the National Health Service in England, which was commissioned by the Secretary of State. This is the second such review Lord Darcy's undertaken, and colleagues will know he's a professor in surgery and a former health minister who now sits as an independent peer. The report is an important moment for us, not least because it concluded that the National Health Service is in a critical condition, and it's identified a number of interrelated drivers for the current challenges we're facing, not least a shortfall in capital spending. This report will be the foundation on which the government's 10-year NHS plan will now be developed, and going forward it's really important for organisations such as ours to help inform the content of that plan. The plan is being led by Sally Warren, who's been commissioned by the Secretary of State to lead this piece of work. I suppose one of the things to highlight from the report as well relates to ICBs. The report concludes that a top-down reorganisation of NHS England and indeed ICBs would neither be necessary nor desirable in supporting the recovery of the NHS, which clearly is encouraging, and again reiterates what we've heard already regarding the government's ongoing support for integrated care boards. And if I may move on to matters finance, I reference in the report our Q1 assurance meeting with NHS England. Following that, we were tasked with submitting a revised financial recovery plan, which we did earlier this month. But prior to that, in light of the ongoing financial challenges we're facing as a system, we received confirmation from both the Chief Financial Officer for NHS England and our Regional Director for the South East that the Integrated Care Board and the wider system had been placed in what is now referred to as an investigation and intervention regime. This is a relatively new initiative designed by the Chief Finance Officer to support those systems which are considered to have the highest level of financial risk, particularly in relation to achieving this year's financial plan. We're not the first system nationally to be placed in the regime. There are a number of others, but we are the first system in the South East. What the regime means is that there will be a two-phase programme of work. Phase 1, which is the investigation phase, will be undertaken over a 4-week period with support from an external consultancy. We have engaged PwC to carry out this work, and the investigation will look at a number of key areas where we can perhaps hopefully improve financial performance. So carrying out an assessment of the grip and control across the system, reviewing pay spend, reviewing programme management office arrangements and our cost improvement plan delivery, looking at non-pay spend, trying to identify other areas of financial opportunity, and also identifying potential weaknesses in our current financial plans. That investigation phase then will inform a 12-week programme of intervention, with the idea being that that programme will see significant improvement in our in-year financial performance. We will be touching on this matter later on in today's agenda, but I just wanted to highlight to colleagues the latest developments, not least because when I wrote this report, we had not yet appointed PwC. If I then may move on to our change programme, board colleagues will be well cited on this and the work that's now been ongoing since April this year when we launched our initial consultation. The consultation period ended on the 4th of August. I'm very pleased to report that we received a wealth of feedback from both our staff, 384 separate pieces of feedback from ICB colleagues, together with 27 separate pieces of feedback from key stakeholder organisations. This feedback has been considered and has been factored into the final outcome of consultation document, which we will be presenting to our board for final ratification at an extraordinary meeting of the board that's scheduled to take place on the 25th of September, so next week. Colleagues will have seen that the change programme has received a fair amount of interest, not least from the Health Service Journal, on the back of meetings we had with Oxfordshire Health Oversight and Scrutiny Committee, both informal meetings and a meeting in public last month. And related to that, we have received a question both from Healthwatch Buckinghamshire and Healthwatch Oxfordshire. The question is, will a summary of the system partner feedback from the consultation be made available to the public? And we understand the extraordinary meeting on the 25th of September will be a closed meeting and not in the public domain. If this is the case, how will the decisions made in that meeting be communicated to the public, particularly with regard to how system partner feedback was used to inform the outcome of consultation and the anticipated impact of the new operating model on the public? It goes without saying that we are committed to providing detailed feedback regarding the consultation. We will be writing to all external stakeholders following the 25th of September, communicating the outcome of the board's deliberations, and that letter will include high-level themed summaries of the feedback we've received from external stakeholders. We'll also be writing individually outlining what this will mean in terms for how the ICB will be working with individual organisations moving forward. And clearly this will be an organic process, and we are absolutely committed to engaging on an ongoing basis with all of our external stakeholders, and the development of the Integrated Care Partnership, I think, will enable us to do that. Sim has already referenced Claire's role, and I'm very grateful for her stepping up to support me in relation to matters governance. She's also now our acting senior information risk owner, so I'm keen that we just make note of that in today's minutes for very obvious reasons. Sim also referenced the fact that Rachel Decaux, our Deputy Chief Executive and Chief Medical Officer, will be sadly leaving the organisation at the end of November. I'd like to put on record my great thanks and indeed that of the wider board to Rachel for all she's done during her time with the ICB. It's fair to say it wasn't a straightforward time, and she's helped navigate some very difficult situations for us, not least when she stepped up and was our acting chief executive for a number of weeks. In addition to Rachel leaving, we've recently received confirmation from Caroline Corrigan, our interim chief people officer, that she will be leaving the organisation at the end of December. So in light of that, we are now going out to recruit both a new chief medical officer and a new chief people officer. That process has begun, and I'm hopeful that we will be able to interview for both positions towards the end of October. There will be panel interviews supported by stakeholder panels, and I'm hopeful that members of the board will be able to attend either the panel interview or contribute to the stakeholder panels. You'll see in my report we've somewhat changed the format, not least including a greater focus on the board assurance framework. I'm very keen that we raise the profile of the board assurance framework, not least because it obviously highlights the strategic risks to the ICB's objectives, and you'll see that there are two particular risks which have the highest rating at the moment in relation to our ability to achieve our strategic objectives. They relate to financial sustainability, very much in keeping with what I said about the investigation and intervention regime and access to services. Moving on, I was able to sit on the interview panel for the Thames Valley Health Innovation Network chair position in July. I'm very pleased that we appointed Peter Ellingworth, who's been a member of the Health Innovation Board for some time. I met with Peter a week or so ago. He's very keen to work very closely with us and indeed all system partners, and offered to come and attend either a board development session or a private meeting of the board, or indeed a public meeting of the board, which I think would be very helpful, not least because I think going forward the Health Innovation Network has a very important role to play in supporting the transformation that's required in services across our system. And I think it's fair to say that the Innovation Network's profile perhaps has not been as high as one would like it to be. So perhaps we could consider taking up Peter's offer and include that on the action log if you're happy with that, Sim. Yeah. And Sim, you referenced the civil unrest, and I can only echo what you said, particularly echoing your thanks to everyone involved in our staff networks, especially the care network, which did some great work to support our colleagues during what were some very difficult and upsetting days and weeks earlier this summer. Rachel will touch on GP collective action in the performance section of the agenda. And before I hand over to the other Rachel regarding matters quality, I just really wanted to say how pleased I am to have been confirmed as the permanent Chief Executive for the Integrated Care Board. I very much look forward to working with everyone sitting around this table and indeed in the wider organisation during the months and years ahead. There is a lot to do, but I have no doubt that we have the wherewithal to achieve the potential both of the ICB as an organisation, but more importantly, the system that is Buckinghamshire, Oxfordshire and Berkshire West. And if I may, can I just put on record my thanks to my colleagues at Oxford Health who supported me during the course of the secondment, who were quite flexible in their approach to me being seconded in the first place, particularly their chairman, David Walker. It was an absolute privilege leading that organisation during the 3 years I was Chief Executive. But I very much look forward to the new challenge that we are embarking on together. Rachel, if I may just hand over to you, because I know there's a couple of issues you want to flag in relation to quality and safety.
Thank you. Thank you, Nick. So again, for colleagues online, my name's Rachel Corser. I'm the Chief Nursing Officer here. Just a couple of things to point out. And whilst we're welcoming the glorious sunshine that we're feeling today, we are focusing on winter readiness. And just to point out to colleagues the work that the team have done on concluding our vaccination programme. And as of the 1st of September, we kicked off our winter vaccine programme, which started this year for the first time with supporting respiratory, still can't pronounce it properly, syncytial virus, RSV vaccinations for those between the age of 75 and 79 and our pregnant women. And from the 3rd of October, we kick off in earnest our flu and COVID vaccination campaign. So please do look out for that. And big thank you to all our partners across the health and care sector for stepping up and putting on their COVID and flu vaccination programmes. And we've got a really good spread this year across the entire footprint of Buckinghamshire, Oxfordshire and Berkshire West. You're seeing there a nod to the work that we're doing around antimicrobial resistance. Some of you will have heard some of that coverage only this morning coming into work on the radio, that this remains a real focus for us and a global challenge, so something that we're responding well to, and we'll be preparing well for Antimicrobial Resistance Awareness Week in November, and we'll bring more of that back next time. I think just lastly wanted to highlight the work that we're doing with our statutory partners on responding to the publication of Working Together to Safeguard Children. So working with our partners across local authority and the police to ensure that we've got our lead safeguarding partner, who is Nick as our Chief Executive Officer, and our designated safeguarding partner, who we have assigned that role to Catherine Elsmore, who's our Director of Safeguarding, and I will be supporting Nick in his role as the lead safeguarding partner as I continue in the executive role for safeguarding. That was all I wanted to point out. Thank you, Nick.
Thank you, Rachel. Very happy to take questions.
Any questions for Nick or any reflections or observations? No, Nick, you've oh, Aidan, excuse me.
There we go. Thank you. Sorry, I should have said Aidan Raven, Non-Executive Director. Nick, you mentioned your audience with the new Secretary of State. Oh, is that the right term? Well, anyway, meeting with the new Secretary of State. Could you just give us a bit of a flavour of the kind of direction he was giving, some of the insights he maybe gave into how he's going to lead the service?
Thank you, Aidan. It wasn't a private audience. I was in the company of many other chief executives and senior leaders. I suppose a couple of things to flag. Firstly, since the general election, I've been to 2 events, in-person events with the Secretary of State. On each occasion, he was very keen to receive questions, and they weren't particularly choreographed events, so that was really encouraging. A couple of things really stood out. One was his desire to work very closely with NHS England, and I think, to paraphrase what he said, was that he was keen to develop a one-team approach. Secondly, an absolute commitment to the missions that were set out in the Labour Party's manifesto. One of those obviously relates to health, and related to the health mission, he highlighted the need for 3 key shifts. So a shift from hospital to home, a shift from analogue to digital, and a shift from illness to prevention. Shifts which really underpin what we're trying to do as an integrated care board and integrated care system. So that was encouraging. On a slightly less positive note, he was also very clear that there is no more money available. So this year will certainly be a very financially challenged year for us, and it reinforced the expectation we've heard from NHS England, which underpins why we're now in the intervention and investigation regime, that there is a clear expectation for systems, for organisations to hit the plans, the financial plans that were signed up to at the start of the financial year. The narrative, as you will have heard, is very much that the NHS is broken, and there therefore needs to be significant change. But as I said in my verbal update, particularly with relation to the Darcy report, but I heard this again from the Secretary of State, there is no appetite in government for a major reorganisation of the NHS, and I certainly heard a commitment to integrated care boards, and my sense is that they are seen as key infrastructure in helping deliver the transformation that is required.
Thank you, Nick. So in summary, a lot happening, and I think for this board to note the risks as highlighted in Nick's report, and I think the BAF really rings loud and clear in terms of the 3 risks: the financial risk, the turnaround, the risk we have around trying to redesign our system and work within the parameters of the financial constraints, and also, what implication that has on our services. So we're very well aware, and this board knows the environment within which it's operating. So I think we're noting the Q1 assurance meeting and the new I&I regime, Nick, which is, you've explained very well. So we'll hear about how that progresses. And the only other thing to note, I think, is from your report is the governance review, which again will help us in terms of structures around the new ways of working, and that NHS England are supporting us in this. But the fact that it cannot distract from the business that we have to do, or the change programme. So thank you, Nick, for that. We shall move on if there are no further thoughts or questions. Okay, so we're moving on to a section now where we can sort of start to illustrate some of the ways in which we're working together. I'm really pleased that Steve McManus is going to talk to us this morning about the Acute Provider Collaborative, and just to remind everyone what that means and how it was set up, and some of the work that it's been doing. So this is an update, but also to understand the development and the progress that has been made. So thank you, Steve.
Thank you, Chair. So for colleagues who are joining us online, I'm Steve McManus, the ICB's Trust and Foundation Trust partner member and Chief Exec of Royal Berkshire Foundation Trust. I won't sort of laboriously go through the paper. I'm assuming colleagues have read the paper, but just to draw out probably three themes. So something about where we've come from. So the Acute Provider Collaborative is a formal partnership now between Oxford University Hospitals, Buckinghamshire Healthcare Trust and the Royal Berks Foundation Trust. So the three kind of acute hospitals within the Bob ICB system. We've probably been working together within that collaboration for certainly 18 months plus. However, earlier on this year, we felt there was a need for a more formal shift in terms of how we were organised as a formal acute provider collaborative. That led to us looking at the governance and sort of formal structures that we have in place. And as you can see, there's a schematic of what that looks like. We now have a chair of the Acute Provider Collaborative Board, which is David Heighton, who's the chair of Buckinghamshire Healthcare. I'm formally designated as the lead chief exec for the collaborative. And we've also brought 3 non-exec directors from each of the boards onto the Acute Provider Collaborative Board and are going through the process of also signing off a formal MOU, Memorandum of Understanding, in terms of how we operate together as a board. So I think this will develop further. But at the moment, it's strengthened the governance and oversight and the sort of bind and tie-in from each of the 3 organisational boards in terms of how we operate. And we have delegated responsibility to the APC board from the 3 boards around certain levels of decision-making, which is contained within the MOU. And that has opened up opportunities of how we can be a bit more fleet of foot in terms of progressing some of the work. So that's where we've come from and what the Acute Provider Collaborative is. Probably something about the current before maybe looking slightly ahead to the future development. So we have 4 formal work programs. We have a formal work program around clinical service redesign, a formal work program around elective recovery and an elective program. We have a program around integration of corporate services. And we've also added a 4th work program, which is around financial sustainability. And that's each of those programs are led either by one of the organisational executives or by the relevant chief executive. So it's got very senior leadership across that. And we are resourced through a funding from each of the 3 organisations that are pooled to provide the sort of capacity and capability that we need to progress that work. So just some sort of current sort of highlights. So within the clinical service programme that's led by Janet Lippett, Chief Medical Officer at Royal Berks, we have currently now stood up a case for bringing together fracture liaison services across the whole of the 3 acute organisations. That will provide over the next 3 years real quality benefits as well as also resourcing benefits for the 3 acutes. But importantly, into next year, it'll provide opportunities in terms of quality benefits and efficiencies that our community and social care partners will actually see. So there's a wider sort of benefit in terms of that type of service. And there are 2 other services that are currently being reviewed in terms of how we look at bariatric services across the 3 organisations and also rheumatology services. So it's some real kind of progress being made in that space. Around our work on elective recovery, we are now seeing the benefits of what we term as mutual aid between the 3 organisations, where we are able to either offer opportunities for patients who've been waiting the longest length of time within our system in services like urology and ophthalmology and orthopaedics, to either have their their treatment offered in one of the other organisations within the system. Oxford University Hospitals Trust has some of the most challenged waits in terms of patients over 65 and 78 weeks wait. And we're now sort of offering opportunities for patients who may not have had their initial appointment currently to be seen either at one of the other two organisations. The other thing we're starting to do now is to actually move clinicians, say particularly from Oxford University Hospitals, to work out of one of the other organisations. So we've now got one of our hubs in Wickham where Oxford University Hospitals surgical staff are operating out of that location, because we're also finding that our patients sometimes do not necessarily want to move from the organisation that they have been waiting to have their treatment. So we are remaining them with their surgeons, but moving the surgical teams to operate out of capacity kind of elsewhere. So we're really starting to see some opportunities there, and that's also sort of flushing out opportunities for how we provide things like corneal graft services singularly across the whole of our geography as well, given the fact that's a limited resource. The third kind of area is our corporate services. We held a cross-APC session led by Neil MacDonald, who's the Chief Executive of Buckinghamshire Healthcare, and we will start to see the opportunities around drawing together at scale our corporate services through the second half of this year and particularly into next year. We're already doing work in terms of how we undertake things like procurement at scale and getting the value of our sort of buying power of three organisations. I think the further opportunities is how we look at some of the opportunities around the transactional services that we might provide within corporate services and trying to do that once across the APC rather than in triplicate. We've got an open book approach in terms of our fourth work programme, which is around financial sustainability. We've already seen work around peer reviews between the organisations on our efficiency programmes, and how we're also starting to plan into 25-26 along with colleagues within the ICB. Looking ahead, across those three programmes, particularly around the clinical services programme, I've already mentioned two of the other clinical services that we are looking at the moment to consider how we provide singularly across the geography of the ICS. But I think there's also a real opportunity working with Hannah and the ICB and also our primary care colleagues about the configuration of clinical services into 25-26 and beyond, when we think about that much more strategically, given some of the requirements we're going to need to look at in terms of sustainable services and consolidation of services. So we see the APC's clinical work programme as a core sort of driver around that, working with ICB and other colleagues. Within elective recovery, we've got a longer-term programme to actually reduce and equalise weights across the whole of the system, and to bring us back to a position where we are eradicating patients waiting over 52 weeks. That's being led by Meghna Pandit, who's the Chief Executive at Oxford University Hospitals. I've already mentioned the fact that into next year we will have our programme around corporate services kind of unfolding, and given the the financial challenges that we've got across the system, financial sustainability is going to be a key issue for us across the APC and our contribution into next year through the planning round within the system as a whole. So I think we've probably to say we've had a reasonably slow start. I think this year has really allowed us to kick on, not least through the strengthening governance that we put in place, which has really seen an important step up in terms of the buy-in of the three boards. One of the other really important areas of focus that we've got for this next 12 months is actually how we get some further sort of OD and cultural alignment between the three organisations, particularly across the executive teams and then further into the clinical teams. But we're already seeing some really good collaboration between our clinicians across the services that we're already working with at the moment. So I think good progress this year and more to come.
Excellent. Thank you, Steve. I think residents will be pleased to hear the progress that's been made. Let me ask if there are any questions or thoughts. There's a lot in that report, but I think it's well put together. So let's ask. Nick.
Steve, thank you for that and for the report, and really great to hear the progress that's been made. And as we see the Acute Provider Collaborative as a key vehicle for transformation, and one of the things that we really need to sort of help support in terms of the transformation that's required across the wider system. In terms of the three specialty areas that were identified, can you just outline how those were identified? What was the rationale behind picking rheumatology and etc.?
Yeah, so we started really through a set of criteria that looked at a desktop review of each of the organisation's clinical strategies. We also looked at data that we had around those various services, length of waits, other data that we had around Model Hospital and GIRFT on our services, and effectively had a criteria that we started with that allowed us to then apply that criteria to a number of service areas. So it could well be about service areas that either were vulnerable in terms of their ability to deliver against the expectations we had quality concerns potentially, or where there was kind of clear opportunities for kind of consolidation and an improvement. Some of it was also where the sort of watercourse went, so where there was kind of willingness and an opportunity to be able to work across the three clinical teams. The first, in terms of fracture liaison, there was a real obvious opportunity and a real willingness of our clinical teams in those areas to consolidate, because they could see the benefit around that. It's a bit of a test case for us, as it says in the paper. We've taken that already through the APC board. Buckinghamshire Healthcare, Royal Berks have already signed that off. OUH is just about to sign that off, and we're already seeing the clinical teams actually working to a single model of service that we will unfold in the second half of this year and into next year. Rheumatology and bariatric services again met kind of criteria about levels of either vulnerability or where we had a differential in terms of the volume of activity we were doing, either a scale of activity in one place and a real subscale somewhere else. So the opportunity to actually consolidate as one service across the whole of the system was one of the criteria that certainly ticked the box for bariatric services. So we've got a criteria that we will continue to apply, and there will be an increasing overlap between the work that Meghna is leading in terms of elective recovery, where we know we've got some vulnerability in terms of our service capacity in areas like ENT, so ear, nose and throat services, with the clinical service development work stream, where we actually may well need to look at more fundamental redesign, because we'll hit a ceiling of what we can do potentially in terms of bringing waiting times down for certain services just because of the capacity demand challenge.
Thank you, Steve. Oh, yes, Hannah. Were you first, Aidan? No,
sorry. Thank you, Steve. Really, really good report. I think it feels really dynamic, and you can kind of get the sense of the potential in it. And it aligns actually really nicely to the report that Nick mentioned in his report from Lord Darcy, where he says that collaboratives should be a means to deliver more integrated care and spread good practice that raises quality and consistency, but it's not often the case, or it's not always obvious. And sometimes it kind of can get stuck in the simplification of governance and thinking about how we might work at scale. But what's really clear from this report is there's more and more examples of how you're looking at the data driving consistency and quality. And my sense is once we start, it kind of then can motor. I think then the final reflection of Darcy is that if collaboratives prove unable to change the way care is delivered, there's a risk that they can kind of be displacement activity. So I wondered how you're kind of managing the balance within your providers, given the fact that we want to drive preventative neighbourhood-based care in places, as well as this at scale across our places. So how are you managing that kind of leadership task effectively across the three organisations?
Yeah, I mean, I think there's a recognition that there's a number of different dynamics for individual organisations in terms of where their collaborations and partnerships work. So we've very much taken the approach within the Acute Provider Collaborative across the 3 organisations about how we have the appropriate governance to actually make decisions on things that are relevant to our work at scale, but also that each of the organisations has other relationships and other partnerships that are kind of equally as important. So we've tried to sort of ensure that there's not a hierarchy of relationships, because our place-based partnerships in each of Oxfordshire, Buckinghamshire and Berkshire West is really, really important to each of those organisations in terms of our relationship with primary care and social care. But equally, the things that we can do at scale are really, really important. I think cranking up the governance has been really important. It's that balance between sort of form and function, because I think a little bit more form has allowed us to really drive the function kind of this year with the sort of board buy-in. But I think, you know, it's that constant healthy tension between the partnerships that we have at scale, but the partnerships that are really, really important to us kind of locally, and also recognising each of the organisations also have other relationships that are outside of the ICS geography, whether it's OUH's tertiary relationships, Royal Berks relationships across into kind of East Berkshire kind of as well as Buckinghamshire has other relationships. But yeah, I think we've got the kind of balance kind of right as it currently stands.
Aidan.
Thanks, Chair. Aidan Rave, Non-Exec Director. Thanks, Steve. Just with an eye on the counterfactual, if you were to apply a kind of force field analysis to this, where would the primary areas of resistance to change be, do you think, in terms of some of the progress that you've made? It'd be interesting just to kind of get a sense of where there are potential barriers, as well as clearly where some of the drivers are that you've articulated.
Yeah, I mean, I think, you know, one of the main challenges is, well, sorry, two challenges. One is what I've just mentioned, which is the sort of pulling forces in other directions, whether it's kind of, you know, tertiary work that, you know, OUH kind of has, whether it is other relationships that individual organisations kind of look to. But I think we've kind of have dealt with that kind of well. I think probably one of the key challenges is always overcoming that kind of issue about sovereignty. So individual sovereignty, and how do you kind of pool risk and opportunity that has a kind of greater benefit when working at scale versus actually how that kind of lands in terms of individual sovereignty. And I think that's an ongoing challenge for us. I think the form that we've created now is helping with that. I think the OD piece is going to be really important, because you actually need that ability to manage accountability within a sovereign organisation, but collective accountability, management of risk, and driving opportunities for the sort of greater good across kind of our patch that the 3 organisations can deliver. And you need that consistently through all of the executive teams and the boards, but more importantly as well, further into the organisation, particularly within our clinical leadership. So I think that is ongoing work. We recognise that, and we've kind of worked with other acute provider collaboratives in different parts of the country to see how they've approached that, whether that's in London or further into the West Country, also kind of working with kind of colleagues kind of up into the Midlands as well. And there are different ways and different models of how they have dealt with that. Some is much more structural, and some is much more about actually a lighter touch level of governance like we've got, even though it's more formal than it was, but actually really driving into the OD piece at senior executive level, but also at clinical level as well. And I think that's our next big step to go even further in terms of that potential barrier that sovereignty sometimes throws up.
Thanks, Tim Nolan, Non-Exec Director. First of all, Steve, I think it's a great paper, really, really positive. I think it's a great example of I know it's not technically been called a relaunch, but a really positive relaunch. I think the structure you guys have put around it seems to be making a real difference. So great, and big hats off to everyone involved. My questions, I mean, Hannah's touched on part of it. They come into sort of 2 real elements. One is around linking with others. So notably, the Mental Health Collaborative, which obviously I'm sure there's a lot of differences, hence the two separate bodies, but there must be some areas where you can potentially link up, procurement being one of them, for example, and I'm sure that some of the back office stuff. So what are the links there is question one. And then the second one, and you've got some really interesting teasers in the paper, and you mentioned it as well about the future and how it might develop into this the left shift, you know, the illness to prevention, the hospital to home, all those sort of bigger things. How do you see that being managed? I know it's a movable feast, but how do you see that developing? Because I think that's, you're getting on your feet now, which is brilliant, or we are, because it's all of us together. How do you see it moving to the next stage?
Yeah, thanks, Tim. Probably two answers. So particularly the work that I've talked about around corporate services is not exclusive to the Acute Provider Collaborative. We're driving that through a specific work programme within the APC, but we're working with the Mental Health Collaborative and our two mental health and community partners on the opportunities at scale. So we know that we've already got a programme of work around that, and we've kind of kept the door open and the dialogue with them around things like procurement at scale. And so we've got an active work in that area with all 5 providers across the system. In terms of sort of future kind of opportunities, I think it comes to the work around the clinical service kind of design work program, and the opportunities there through I suppose testing and learning through things like the fracture liaison kind of service work about how can we actually bring services together. It's a bit of a test case for us, because if we weren't able to effectively land this, there's a real question about kind of what can we land in that space. So it's been a real test for the APC board and leadership around kind of landing that and moving that on. But it also takes us into territory of kind of working with George's kind of colleagues across primary care, because of, you know, how do we make sure when we're thinking about service redesign, service consolidation, that actually it has a positive bearing, not just in terms of the 3 acute organisations, but a positive bearing on our community services, our primary care services, in terms of the way that we work. So I think the more that we do this work with specific service areas, it'll take us further and further into not just the benefit for patients within the acute provider collaboratives orbit, but actually how does this support the sort of redesign of services with our primary care partners, our community partners, and our social care partners. The fracture liaison service is a really good example of where there's benefits across all of those kind of organisations for patients.
How do you see yourself bringing in the local authorities in that, when you're doing that redesign? Because a lot of our pathways touch local authorities and voluntary sector groups. How do you see them? So we're not just looking at the NHS.
Yeah. So the fracture liaison service is a good example of where that's kind of a case in point. You know, I think that'll also be driven through the strength of relationship that we have with in-place partnerships. So that's always going to be the really healthy relationship that we need to manage between the acute provider collaborative opportunities at scale and the implications of the impact of how we look at service redesign and service improvement at a locality within place, not just for the implications for partners like local authorities and primary care, but also when we're thinking about those service developments and service redesigns, how do we do that with and through the public and make sure that we've got good public engagement where kind of we need to in terms of the service improvements that we're making. And indeed how we do that through the ICB, given your sort of unique place to look at public engagement and public voice within all of that.
Thank you, everyone. I think you can tell by the level of questions and discussion, Steve, that the paper's very welcome. We absolutely note that move into slightly more formal governance, which has allowed for better decision-making and for actual action and therefore impact on our residents and on some of the services and therefore our delivery to residents. And I note as well that sort of left shift that you're starting to talk about, community hubs and this sort of thing, and that's really is very important to all of us, including this current government. So we thank you for the very detailed report, and that was really encouraging. At a time where things are difficult, we still are able to produce work like this and come together as a system, and then connect all of the parts, as Tim said, local authorities, our voluntary sector, and you'll note you're constantly talking about place and the importance of all of those other partners and us delivering together. Thank you, Steve. Right, with no further ado then, perfectly poised and a lovely segue into our place report, which comes from Berkshire West, this particular meeting. So I'm going to hand over to Matthew Tate, who'll give us some context and introduce the piece. Thank you.
Great, thank you, Chair. So Matthew Tate, I'm Chief Delivery Officer for the ICB, and yeah, I think there's a really nice link between the APC and this debate, and to Steve's final point, I think that we need all our partnerships to be really strong and well developed if they're going to work well together. So it's a nice link. Before handing over to Helen, who's Deputy Place Director, and really pleased that she's been able to join us today, I wanted just to give the board a little bit of reassurance around how we're continuing to support Berkshire West, given some of our staffing challenges. So obviously Sarah is off on maternity leave and will await the birth of her baby, but we also have a gap in terms of the urgent care director in the Berkshire West system that we've been managing now for 4 to 5 months. So I just want to give a little bit of reassurance of how we're covering that and ensuring that we're supporting Berkshire West place developments before Helen gives an overview of some of the priorities. So we do have, in the urgent care space, we have both Hannah Mills and Debbie New from the urgent care team leaning in to support the Berkshire West programme and plans, and particularly around the development of the urgent care centre, which I'll come on to in our performance report. We have Rob from Hannah's team involved in the new hospital programme that obviously is an important priority for the local partnership, and our mental health and LD team, Nikki Cartwright and support the really important SEND agenda, which again we heard about from our patient story today. And then in terms of executive level, so we've shared amongst the executive the attendance of the health and wellbeing boards at a local level, actually, to give some insight and senior support to Helen in those. So I'm attending Wokingham. A combination of Rachel and Abid are covering West Berkshire, and then Rachel is going to lean in and support Reading, and I'm going to attend the Unified Executive, which is the sort of formal NHS element of the place-based partnership, over the next few months as we model that. So just to give the board a reassurance that we've got arrangements in place to lean in and make sure that Berkshire West still has the necessary focus from the ICB. But I wanted Helen to have a few minutes to outline some of the priorities that the place-based partnership is working on. So Helen, over to you.
That's great, thank you, Matthew. So yeah, I'm Helen Clark, I'm the Deputy Place Director for Berkshire West. So hopefully people have got sight of the slides that we've got, so I'm just going to briefly take us through those if that's okay. So just giving a bit of an overview of our place-based partnership. First of all, conscious we've got Steve and Minu here as well, who may also want to share perspectives on some of this. I'll talk briefly about our current areas of focus, and then I'll just touch on some of our kind of strategic priorities at place at the moment. So just a kind of reminder, first of all, of our footprint, which I think is fairly complex. So population-wise, our 560,000 residents, about 80% of non-specialist acute care is accessed from RBFT, the remainder a combination of Frimley and Hampshire. We have Berkshire Healthcare Foundation Trust providing community and mental health services, obviously with the overlap with the Frimley area. We have our Berkshire West Primary Care Alliance, a GP federation, of which 14 of our 17 PCNs are members. And then people will be aware that within Berkshire West there's 3 local authorities, and that our Health Watch and voluntary sector configurations also reflect that 3 local authority footprint. So that complexity is reflected in our place-based partnership arrangements. We have 3 health and wellbeing boards, and associated 3 locality integration boards and children and young people's partnership boards. And at a Berkshire West level, we bring some of those discussions together through our 3 place-based programme boards, which cover urgent and emergency care, children and young people, and mental health and LD for adults. And then through our unified executive meeting, which Matthew has referred to, which is really our senior level forum for working together on areas of common interest and where we consider the areas on which we can best make an impact through a collaborative approach. So currently, the Unified Executive has identified 4 areas of focus where we are sort of concentrating our collective efforts. So I'm just going to say a few words on each of those, if that's okay. So the first area that we're focusing on is same-day access. I think access is a key priority for all of us as a system, supporting people to access timely care in the most appropriate setting, whilst also focusing on the sustainability of our services and delivery of access targets. So we've got 3 sort of work streams within this. The first is focused on the current urgent care centre in Reading and putting in some additional support linked to RBFT over the winter period. The second area is thinking about the more sort of medium term, next couple of years, what that service might look like in that period, and considering whether we may also need hubs within our other locality footprints at place. And then thirdly, we're working on a more sort of strategic work stream, looking more fundamentally at our future model of same-day care and how we can offer a more bespoke response to patients. We already, in common with the rest of Bob, have high levels of pharmacy first activity taking place, whereby patients are able to consult pharmacists around particular minor illness conditions, and general practice is also able to refer patients to pharmacies for those conditions. And that's starting to have a good impact, supported by the fact that we've now identified a link pharmacist, or a link community pharmacist for each PCN to really promote and drive that initiative forward. Alongside this, we have a number of our PCNs and practices using segmentation on their clinical system to support them in assessing patients' needs based both on their presentation on the day, but also on information about their sort of underlying health needs. And that's enabling those practices and PCNs to better target care, which we hope to build on going forward. So that we're able to provide timely advice to sort of non-complex, acute, on-the-day needs, whilst also focusing our resource and capacity around providing more continuity and coordinated care for patients with more complex conditions. So moving on, a second area of focus is around SEND. So we've obviously touched on that already in the meeting today, and I think it was really helpful to hear from Gloria to put some of the work in context. So Rachel and others are continuing to work very closely with all of our local authority leads and providers around SEND priorities, developing ongoing strategies and delivering plans and preparing for forthcoming inspections. There's various work underway, including dry runs of processes and testing out of information systems. Also work to develop a SEND dashboard, which will enable us to better monitor delivery at any time and understand how we're doing on the SEND priorities. A specific focus for us within the place-based partnership is on the therapies review. So a review was commissioned from Clarity last year, following feedback from previous SEND inspections and also from parents and carer forums around the complexity of our provision arrangements and how sometimes that can be quite difficult to navigate. And following that review, we've now agreed a number of work streams which will take forward its recommendations and will report into our Children and Young People's Programme Board. A further area of focus is mental health support teams in schools. So we currently have 7 teams in place provided by our local authorities, 5 of which are fully operational. They're covering currently 61% of our school-age population, offering a combination of interventions for individuals with sort of fairly low-level mental health need, opportunities for referral and signposting for more complex needs, and also supporting schools to provide whole school approaches to improving the general mental health and well-being of their student populations. The ICB will be moving into a procurement process for these services over the coming months, But prior to that, we've been engaging with partners, existing providers and service users to really scope the type of service that we want to commission going forward. And we will be looking to improve coverage, particularly of the whole school approach that I've mentioned, but also to commission a service that very much evolves to reflect emerging best practice, that's able to target its resources around areas of particular need, and that is continually co-produced with service users and schools to really kind of engage and develop the service going forward. And then the final area that I wanted to mention was the Community Wellness Outreach Programme, which I understand has previously been presented to the board, so I won't go into too much detail on that. However, I'm pleased to say it is now in the implementation phase. All 3 of our local authorities are now working to deliver the service in partnership with the voluntary sector and others. It's very much focused on providing enhanced health checks in community settings for patients who might otherwise not have accessed core services. And we've got clinics happening in all sorts of community venues, providing a combination of booked appointments for people who've been identified on GP clinical systems using population health management data as potentially benefiting from these checks, and also walk-in sessions. So the data is very much evolving on that service. The early data does indicate that we're doing well in terms of reaching the target groups that we're trying to reach, and also that we're identifying quite high levels of people with high BMI, high blood pressure, or high blood sugar, and enabling referral on to other services as a result, or to more general health and wellbeing advice. But this is also really an example of how we're working in partnership. It involves RBFT, it involves the voluntary sector, it involves local authority, and also external partners. So it's very much a kind of test case, both in terms of prevention, but also in terms of what we can achieve by working in partnership. So we'll be doing some evaluation work over the coming months, but as a place-based partnership, we'll be looking at this very sort of closely in terms of potential for future work, particularly in the preventative space, which is an area which we want to further define our approach to. So that probably just brings me on then to looking forward. So as well as that work to define our approach to prevention, we're looking to undertake some work around future models of care and care pathways, with a particular focus on what community pathways look like going forward and the role of integrated neighbourhood teams. That work will be intrinsically linked in with the Building Berkshire Together New Hospital Programme and the work that's underway to define the shape of future hospital provision. So in a sort of early stage in terms of our place-based partnership involvement in that, but certainly an area of focus. All of our integration work is underpinned by the Better Care Fund, and we want to work with health and wellbeing boards going forward to review the use of the Better Care Fund and obviously to respond to further guidance as it comes out for what that might look like post-2025. And we will also be continuing to develop and review our place-based partnership arrangements in the light of the ICB's new operating model and the changes associated with that. So that probably is the sort of where we're at currently. I will just bring Matthew back in if you wanted to add anything on that point. Thank you.
Helen, brilliant summary. Thank you very much. Perhaps, I don't know if you want to give Steve or Manu the opportunity to add before opening it up to questions, Chair, if that's okay, but nothing else to add. Helen, thank you very much.
Yeah.
Thank you. I can speak only on behalf of the mental health and community health services in Berkshire Healthcare, and I think we are fortunate to have excellent relationships which have been established over years with a high-performing acute trust, a very forward-looking primary care alliance, and that sort of developing trust makes it possible to address the challenges which we all face in our individual sectors. So I can only thank colleagues from both acute and primary care, and of course the developing relationships and the support we get from our local authorities to make a lot of this possible, which we've just described. So all in all, I'm very optimistic for the future of the population of Berkshire West. Thank you.
Sorry, Tim was first.
Tim.
Thanks, Sim. Thanks very much. First of all, thanks very much, Helen. Really, really great report. Really concise, but really clear. So brilliant. I'll give that a little bit. Just had two questions. The community wellness outreach, which just I have to say sounds absolutely brilliant. It's exactly what I think, as a relative lay person in this, it's exactly what we should be doing. It's this move to prevention. It's getting out there, engaging with people, the hard to reach groups, inequalities. It's just absolutely outstanding work. So thanks to you and everyone involved, and please pass on that to the teams. Linking that to the point before about the mental health support teams in the schools, again, brilliant work, and it sounds good. The common theme, or one of the common themes of me, both those, is this is such good stuff. Are we sure and confident as an ICB that we're doing similar stuff in Oxfordshire and Buckinghamshire? Now, I'm sure they are. I can't believe people are sitting on their hands not doing this great work. But it naturally begs the question about full system working, particularly when we talk about re-procurement, that it logically says, I mean, you guys are managing to navigate a complex landscape even in your own area with the 3 local authorities and so forth, and you're managing to do that. So, again, rather naively, it strikes me as, well, why don't we sort of just stretch that a bit more and get Buckinghamshire Council and Oxfordshire involved and at least make sure we're doing things in a standardised way, etc., etc. Of course, it needs local adjustment and tailoring, accept that. But are we looking at that in a holistic system approach?
Might get Matthew to pick up on that.
Yeah, I'm sure I'm more than welcome to Helen to add from a Berkshire West perspective, but probably a little bit unfair to comment on the wider picture. Just a couple of comments. So I think the mental health in schools teams is a national initiative. It's implemented across Bob. Obviously, there is local nuance in terms of models and providers, actually, across the system. So in some sectors, we've got NHS providers. Obviously, in local, as Helen's outlined, in Berkshire West at the moment, it's a local authority-run model. So that model is consistent, standardised, similar specs across the system, and being rolled out nationally and locally as well. In terms of the inequalities one, again, Rachel may want to come in on this, but I think it's key that I think some of the work we've done on health inequality has been really proactive, allowing our local place partnerships to focus on their need and their initiatives that they think will have the biggest impact. We've got an evaluation framework around all of that to look at best practice, to look at sharing, and obviously we've got a health inequalities board that is taking a system view on that as well. So we're at the early days of lifting up and sharing in those areas, but I think we've got the processes and the mechanisms in place to do that, Tim.
Thank you. So I've got Nick, George, and then Saki.
Thank you. Helen, Matthew, thank you for the report. Just 2 things from me. Firstly, in relation to the overview slide, it looks as though the 3 PCNs that chose not to join the Primary Care Alliance are all in Wokingham. Is that correct? My second question relates to the mental health schools teams. When do we think we'll have full coverage across Berkshire West?
So on the first point, they're not all in Wokingham. No, they are more spread than that, but we do engage with those 3 PCNs as well as you would imagine. With regard to the mental health support teams, I'm afraid I can't answer that question here and now because we are still working up the procurement and what we can achieve through that procurement, but we're certainly looking to expand coverage as part of that exercise.
I think there's probably a national timeline on that, Nick. Happy to take that away and perhaps confirm what the national ambition is, because that will be in part, I think, funding and rollout dependent. But I'm happy to take that on internally.
Can we include that as an action, do you think, Claire? Thank you.
I'm George Gavra. I'm the partner member for Primary Medical Services. Thank you, Helen. Missing you in the primary care team, I'll say. I think, with regards to primary care strategy and probably prior that, Berkshire West certainly is seen as a kind of leading light in moving same-day access forward. I do kind of note in your slides there's reference to a current pilot with Reading Urgent Care and an interim pilot at Royal Berk, so 2 pilot projects. Just, whilst I think it's important we've got, we need to look at local needs within place, which are different. We've got different services in those areas. Just wondering when the outcomes from those pilots might be shared so that we can sort of take the best bits and steal them across the rest of the system.
Yeah, one thing I should have said, and apologies, it was scribbled in big letters on my notes and I didn't get to, I mean, that same-day access work we're undertaking with the primary care team and absolutely as part of the implementation of the primary care strategy. So, yes, any information will be shared across as it would be from other areas, but I know Rachel wants to come in.
Thanks, Helen. Rachel Deco, Chief Medical Officer. So on that point, we will be bringing an update on the primary care strategy implementation to November public board, but also following on from a very successful event where we brought together colleagues from across the disciplines of primary care to do exactly that, to share learning and spotlight. We plan to do the same, given that each of our places is forging ahead, quite rightly, with different aspects of the primary care strategy to make sure that we can share that learning and good practice as it evolves.
And finally, Saqib, to close.
Yes, Saqib Ali, Audit Chair. As a former, or briefly, a teacher in schools and colleges, and I think Priority 3, the mental health support team's question, though coming last, most of them have been asked. But what I wanted to delve a little on was the service cross bob, and which you'd mentioned, and how we're going to get to the 100%, which has also been covered. But I think the reason why it's really important is the impact on educational outcomes. And, you know, it's well rehearsed about access to CAM services, EHCP, which there may be great demand currently due to the impacts on private education, and then young carers. So it was just to see that in the round that we have early intervention and the length of waits for young people to be seen, and across both primary, secondary education and colleges. But I think it's a really important area, and thank you for your presentation.
Thank you, Saqib. Well said. I think you can tell from the questions and the observations that this is a very important area of delivery for the ICB, and I just thank you for the report, which is really clear and really noting, you know, the priority 3 and 4 in the prevention space, which is exactly where we need to concentrate on. And I'll just pick up on that point about the school coverage. So the action is to understand nationally where the target is, but also from us individually as an ICB, do we want to, you know, run as fast or, you know, more slowly than the national ask? So that would be very good to get back to. So thank you, colleagues. That closes this part of our meeting. I'm going to give everybody a break, a comfort break. And if I could ask you to come back at 11:45, please. 11:45. Thank you. So welcome back, everyone. We move now into the operational section of the board meeting, where we're looking at performance and quality and finance into the gritty issues. So I think to begin, we're going to ask Matthew Tate to take us through the performance and quality report. And what we're looking for is assurance here on matters being handled correctly and mitigations being taken. Thank you, Matthew.
Thank you, Chair. So Matthew Tate, Chief Delivery Officer, and I will be relatively brief and just perhaps bring the board up to speed, as I often do, Chair, with slightly more up-to-date metrics, just to give a feel for the latest position on trends. And I will cover urgent care, planned care, mention cancer briefly, and then open it to the Rachels to pick up quality and primary care. And then we'll open for questions. So around urgent and emergency care, you can see the numbers around the key 4-hour performance target in the pack. We have continued to be better than plan, actually, for A&E performance as a ICB. That continued throughout the summer, and some of our numbers in August were very good. We have seen a drop in September, the first couple of weeks. That's a trend that's happened regionally as well. I think probably as the schools come back and demand picks up. So we have seen a drop across all our providers in September. So we need to keep a close eye on that. And at the same time, I think, as Rachel also mentioned earlier, we're in the midst of winter preparation, so all of our local place partnerships are working through their winter plans around urgent and emergency care. And all of them have additional initiatives going in to support winter in one way or another, or we have additional capacity going into BHT on the back of the capital funding nationally that they received last year to put additional capacity in. Oxford have established a new observational unit and are putting in additional ED staff and overnight as we go into the winter. And we've already heard about some of the work in Reading around ensuring that the existing walk-in centre is extended across the winter, and working with our BFT and partners around a UCC model on the Reading site. So there is work going on to prepare for winter, but we have seen a slightly challenged performance recently. The other thing that's probably worthy of note is ambulance performance. So SCAS have had a South Central Ambulance Service have had a difficult couple of months in terms of Category 2 performance, noting the national ambition to get to an average of 30 minutes. We've been running well above that for the last couple of months. I think that's a combination of a number of things. It continues to be a causal factor related to handover delays in terms of performance. Generally, we're not a bad performer on handover delays. As Steve will know, occasionally the Reading site is challenged generally around space constraints, around handover performance, but we continue to work with the trust around that. But across the system, across the SCAS footprint, there are major problems on the Portsmouth site that are well documented, that do have an impact across the footprint in terms of Category 2 performance, and do mean that actually recently SCAS have struggled to achieve those targets. So we'll continue to work with the Ambulance Trust on focusing on handover performance and also diversion work in terms of using some of our out-of-hospital services to avoid A&E admissions. So that's a quick overview on urgent care. In terms of planned care, the focus continues to be on removing 65-week waits. I think Steve referred earlier to some of the challenges that Oxford is having, particularly in that space. So all our trusted plan to remove 65-week waits by the end of September. At the moment, the Oxford University Hospital Trust is probably looking to have a significant number above that, probably in the regions of 300 to 400, and we're working with them in terms of specialty by specialty pressures to use some of that mutual aid that Steve also referred to earlier in trying to get those numbers down. That has been limited, I think, in the first 6 months of the year, but we've got clearer plans in place for the second 6 months to really utilise some of that capacity. And we're also having to go outside of region to try and get some of the support in particularly challenged specialties such as plastics. And I think it's worthy of note, partly because my chief exec may have asked me the question recently, to note that if you look in the detail of the pack, you'll see overall waiting lists are not really coming down across the integrated care board. So that really is the long-term challenge of this system, as Steve again referred to, around the acute provider collaborative. So what is our 3 to 5 year challenge? There is data validation to do on those, but we are effective at starting to reduce the long waits, but we have got quite a backlog in terms of our overall waiting list. In terms of cancer, we've had, I think I've reported to this board before, cancer performance has gone up and down over the last 12 months or so. We're below target in some of those areas this year, and mixed performance across our trusts, generally better on the faster diagnostic standard, and a bit more challenge on 62-day delivery. But all our trusts have good recovery plans in place, and given that we have turned the numbers around, we did turn the numbers around last year, I'm confident that we will see our trusts moving back to trajectory where they're not over the next few months. We've also allocated Thames Valley Cancer Alliance funding to support some of that recovery, and we can see the additional clinics and work that our trusts are putting in place to address some of those numbers. So I think they're the highlights from my perspective. I was always happy to pick up details around questions that board members may have, but I'll ask Rachel C. first to give a quick update from a quality and mental health perspective, and then come to Rachel Dicko.
Thank you, Matthew. So again, for colleagues online, my name's Rachel Corser. I'm the Chief Nursing Officer here at the ICB. Just 3 things to share with the board to provide some additional assurance above and beyond what's in the pack. So in terms of treatment escalation areas, some of us will be quite close to the work that we're doing on preparing for winter, and part of that is how we support our trusts and clinical areas in response to surges in demand. And we're working with our colleagues from NHS England on supporting trusts with reviewing the oversight and quality of care should their need arise for patients to be cared for in treatment escalation areas, particularly in and around our acute and emergency areas. And you'll have seen in the Chief Executive's report the work that we're doing with our colleagues looking at escalation of support and demand for mental health services as well, and that will come back through here in due course. Secondly, just to note the work that we're doing in responding to the patient safety response framework, and we've got a whole board development session next month on that. But that's particularly important to note with reference to the 2 Never events that we've reported this month that relate to Never events historically in 2 of our providers. And I think as we embrace the new approach to learning, the importance for us is about how we monitor themes and trends that are coming through from that. And we've got a deep dive coming into our system quality group this week that looks at the lessons learned from our Never events that we are seeing. And similarly around the work we're doing, just reflecting what Matthew was saying on the patients waiting for care and treatment in our system, we're looking at how we support our providers with the harm review process across all ages, and again picking up the lessons learned from that. Then lastly, just to talk about maternity and neonatal services. So we're working with our partners on supporting their maternity incentive scheme readiness, and this is now year 6 of the scheme, and working with them on their incredible evidence that supports them coming forward with their declaration around their maternity incentive scheme. And then lastly, I just wanted to note the work that we continue to do with our colleagues at the Oxford University Hospitals Trust, particularly recognising the conversation we had last month around the support to the Trust in responding to the publication of the dossier into the 50 cases that were referenced following care and treatment at both the Horton and the John Radcliffe. And as we agreed at the board last time, we've now met with the Trust and the Keep the Horton General Hospital group, and will continue to undertake that engagement work with them as we consider what a further response and review to that might look like, and we'll continue to feed back through board. That was all I wanted to note, Chair. Thank you.
Thank you, Rachel. Hand over to Rachel Dicko.
Thank you, Chair. Rachel Deco, Chief Medical Officer. So I just want to touch on all aspects of primary care very briefly and on the GP collective action. So first of all, you will note there is a slight decline in month 3 primary care access. It's not statistically significant, and actually the most recent data shows the same increase, so not concerned. We will be bringing through Population Health Patient Experience Committee the Primary Care Patient Experience report at the next committee. I think it's really important that we're triangulating all the data. With reference to the GP collective action, that commenced on the 1st of August. As we've previously stated, there are 10 suggested actions that do not breach contracts, and actions may be different at every practice. Really important to say that practices remain open and seeing patients, and the public do not need to behave differently. We do have an incident management team within the Integrated Care Board that shares intelligence, also cross-border with Frimley, and we have got a risk associated with this collective action, which is under emergency preparedness and resilience, and that also includes the other disciplines such as community pharmacy, which of course may be impacted by this action. Some of the specific issues we're starting to see is around Script Switch, which is prescribing decision software that some practices have chosen to switch off. We are also seeing some data that may suggest we are not prescribing the most cost-effective medication, and this clearly will have impacts on prescribing budgets and savings. Other areas that we're keeping a close eye on are the use of letters rather than pro formas, which may impact our trusts and patients where information is incomplete and may lead to additional processing times. And we are keeping a really close eye on future impact. We're expecting the collective action activity to increase, further unfunded work to potentially stop. We're watching very carefully with our providers any access issue, whether that's around non-elective or planned care pathways. And we're also looking around the engagement piece, because we've got a big piece of implementation work around primary care strategy that we want to make sure that we are delivering. With respect to the broader primary care, dentistry, Berkshire West and Bucks access are actually back to pre-pandemic levels. We have access issues most notably in rural parts of northern Oxfordshire, so we're focusing efforts with the recruitment incentive scheme, recommissioning extra activity in that area and expanding the flexible commissioning scheme. The performance report for board looks at performance against operational plan metrics. Population Health Patient Experience sees the full suite of primary care metrics, so just really important for colleagues that are in pharmacy, optometry and dental. We know they're critical pillars in our collective ambition to transform primary care, and they're hugely valuable to contributions to the system. So Pharmacy First, our new hypertension monitoring pilot in dentistry, and a minor eye condition scheme that's been provided by some high street opticians. The ICB are really delighted with the progress made in Pharmacy First. There's around 17,000 patients every month that are supported as part of the scheme. And just of note, the most common condition supported is of a sore throat. But all of that detail comes to board committee. Thank you, and of course happy to take questions.
Thank you. Thank you, Matthew, Rachel and Rachel. Just a quick matter of clarification from me. The primary care action or the GP action, what is the timing of that? When will it end? Is there a specific end date?
So it's an enduring action. So there is no end date until, until negotiations progress. So from the 1st of August, which is why there are 10 possible actions on the table, and we are likely to see further increase implementation and rollout of those actions across our geography. Fortunately, we have really good relationships across primary care, and we are, of course, working very closely with colleagues and monitoring impact.
Thank you. Let's take some questions then. Just, Matthew, remind us the data, April to July, is what we're looking at, but you included some up-to-date reference to performance. Is that right?
That's
So
right,
the
yeah.
data
The data is generally up to July.
Yeah.
They will flag when it's not that period.
Okay.
But I didn't give too many specific figures because they're not in the public domain, but I gave a sense of trends
Yes,
and
exactly.
overall numbers.
Perfect. Thank you for that clarification. Saki.
Thank you. On dentistry, I just had a question. You mentioned the rural areas. Do we use dental buses in this area? I don't recall being mentioned in the past. And on the increase in the number of appointments, at my other ICB, I heard recently that the remuneration for work is only 70% of the actual cost, and they're doing a top-up. So I was wondering whether we have any plans of some form of top-up outside of the national contract. And then just there's a typo on page 74 where it says the payable reduction will be 9.061 billion, which I'm sure it's possibly 1,000 rather than million at the end.
So, Saqib, dental buses are under consideration. So our colleagues are looking at how we best commission, but at the moment we're recommissioning a total of 88,000 extra units of dental activity in those specific areas and are getting good uptake on that. The second bit is we are implementing as per the national dental contract. So we will implement the recruitment incentive schemes, but we will not be operating outside of the national dental contract.
Thank you, Rachel. Tim? Oh, sorry, it was Aidan first and then Tim.
Thank you. Aidan Rave, Non-Executive Director. Just in terms of forecasting, the resolution of the recent resolution, should I say, of some of the industrial disputes, have we assumed in direction of travel that those were going to be resolved, or will, in effect, some of these trends be boosted by the fact that we've gone beyond, hopefully for good, some of the industrial disputes that we've seen over the last couple of years? Does that? Yeah, I'm trying to think about how to frame that.
Yeah, and I think probably we've discussed at the board before, generally, right or wrong, our forecasting and planning assumes no industrial action, and therefore it's a risk to delivery. So it won't improve the number, and obviously, whilst the junior doctors news is welcome, as Rachel mentioned, there is a potential link between ongoing collective action and impact on elective pathways as well, so we just need to keep a close eye on that. But no, the easy answer is it won't give us an unplanned boost.
Thanks, Tim. Tim Nolan, Non-Exec Director. As a question for Rachel, regarding the collective action, you mentioned this suite of 10 potential activities. Are we seeing a trend or consistency in that, you mentioned scripts, which, if that's the correct phrase, 3 are being focused on, and therefore it allows us to better plan, albeit still a pain, or is it seemingly random?
So George may also want to comment. So what we are seeing very strongly promoted and taken up in certain practices is the limit on patient appointments, so the 25 appointments. That has been sort of strongly suggested, and the problem is it's up to individual practices how they choose, and they can change depending on what day of the week it is, and they do not need to notify us. So that's why it is an incredibly difficult picture to keep track of, because you're trying to understand what is just normal variation and what is specifically linked to this episode of collective action.
But we're not seeing, for example, 6 of the things not being used by anybody, as in 6. It's definitely a little bit of everything all over the place, sort of thing.
There are definitely some that have got a greater degree of focus than others. One of the areas, for example, is one of the actions, and Tori may want to comment, is around switching off data sharing. It is quite difficult in some cases to switch off data sharing that doesn't directly impact patients, and people, it has been clear that they really do not want to compromise the safety of patients during this collective action. So there is some variation in that space.
George, and then Nick to close. Thank you.
So 2 questions from me. I mean, one is around collective action and industrial action. Given the nature of collective action is effectively a work to rule, work to contract, as opposed to industrial action, do we anticipate any financial support from NHS England in the way that we have with industrial action previously, when that's come about? And the second really is around the AUH elective long waiters. I mean, a 15% increase in long waiters in 1 month, it looks like, on here, so going from 975 to over 1,100. I mean, do we have any kind of root cause analysis as to why there's been a deterioration specifically when even maintaining would have been a significant improvement on that?
Shall I take the collective action first and then hand over to Matthew? So currently there is absolutely no indication that there will be any financial compensation from the centre in relation to collective action. What we are being asked to do, though, is to collect very carefully. So, for example, when we can obviously see that our savings schemes, particularly in primary care prescribing, have been impacted, to make sure that we are collecting what the quantity, the scale of that impact is, but absolutely no indication that there would be any financial compensation.
And without going into too much detail, George, because it obviously is something we do crawl over quite often in terms of the change in the numbers. A couple of examples of the shift has been in particular staffing shortages and staffing illness, and also in 1 or 2 cases where there's been insourcing, which is or outsourcing of clinical care, where actually the provider hasn't been able to treat the cohort of patients initially identified, and therefore that has had a substantial impact. There are other reasons, but they're 2 that we've seen over the last couple of months as specifics.
Matthew, really pleased you mentioned the size of the overall waiting list, my new pet subject. Moving forward, particularly when we're able to enhance our data analytic capacity and capability, do you think we will be able to sort of drill down in some detail and see whether the more deprived groups in our local population are overrepresented on that waiting list?
Yes, I think that we did do some initial work with the trust, probably maybe 6 to 12 months ago, to look at that now. So it is something we can refresh, and I'm happy to take away the challenge. I'm not sure it's necessarily a data issue. I think we probably can get access to that data, but I'd take that as a check and just see if we can rerun, or how trusts are working on that risk assessment as well. I'm happy to take that as an action.
Tori, do you want to come in?
Thank you, yes. Excuse me, just to note, we do have some of that information. It's a case of bringing it together into cogent reporting. So yes, and there's an action we took through the Patient Experience and Population Board that we were going to look at bringing that together with the new data architecture. So we will be able to report back on that going forward. Yeah.
Excellent, thank you, colleagues. It related obviously now to this, let's move on to the finance report, which is month 4 specific. We've got to consider the ICB's financial position and our ability to meet our control targets. So Matthew, if you can take us through where we are and the mitigations and what we're looking at to try and stay within those parameters, please. Thank you.
Matthew Metcalfe, CFO for Bob. The month 4 position overall as a system, people will have noted the 61.4 million deficit. We have some numbers now through for month 5, which show a marginal worsening of that overall deficit, but equally within the level of expectation when we go back to month 4, when we were asked to report, and I think Nick has mentioned this already, report to NHSE on what our trajectory would be through to the end of the year. So a slight worsening in that position. We'll report more fully through SBC in due course. Within the ICB, there's a slight improvement on the 10.5 million deficit that we reported at month 4 going into month 5. I wouldn't read too much into that at this stage, not least because 1 month doesn't make a summer, in the sense that we've got quite a few one-off items going through. So I think until we've seen the position as it evolves over the course of the next 2 or 3 months, it'll be hard to get full confidence that we're heading in the right direction. But nonetheless, some glimmer, at least, of an improvement there. In terms of where the risks are, I think overall taken as a system, we've got quite a significant gap, which we made pretty clear to NHSE in terms of our ability to get to break even, albeit that nonetheless we were reiterated our commitment to get back to break even. Indeed, NHSE have repeated the fact that there is no more money and essentially there's no bailout. We need to deliver to plan. The size of that gap is considerable. We'll explore that a little bit later on this afternoon when we go through the recovery plan and the details of that, and indeed sort of build on the conversation we've already had with the SPC, the System Productivity Committee. There are some particular risks I would draw out. I think they're threefold. One is around prescribing, which Rachel has already noted. There was a reasonably significant SIP programme attached to prescribing within primary care, and the script switch, lack of attention or more is a significant factor, and as Rachel again has already said, it's really hard to see any even acknowledgement, frankly, of that from the centre at this stage, but I think we should continue to track it very carefully and how we play back the narrative to NHSE and frankly to ourselves in terms of how we mitigate. Secondly, around contracts, we've still got, well, we've made reasonably good progress on contracts in closing down risk, but there is still a reasonably sizable risk around contracts. In fact, two notable ones still remain outstanding, one to do with SCAS and another to do with RBFT. We are working actively on both of those to close them out to the point where we can sign contracts, and that is a source of inquiry from NHSE as well, but that remains a risk. And thirdly then around SIP, as noted in the month 4 report, we were doing work around improving our grip of what should be expected around SIP, particularly within the ICB, and I think there are probably greater levels of risk than at present we're acknowledging in terms of how we bring that back and what contribution it can make to mitigate our current overspend. The final, that having been a sort of an ICB view of the world, the final point I think to wrap up from a system perspective is that we've had meetings now with both OUH and RBFT with the regional team, the regional CEO and CFO, giving us a collective opportunity to discuss forecast to year end. It's safe to say, I think, that we continue to look for more assurance about the ability to meet year-end plan. Each of those organisations are working very actively in order to close down and minimise that risk and build up their portfolio of mitigations. At the same time, I think we all have to acknowledge that has got a considerable task at hand in terms of actually delivering that. A lot of those are associated with delivering on workforce plans, although not exclusively. Workforce remains a very key focus of attention for us all, given the demands I think that we had at the beginning of the year within our plans to mitigate against agency cost, bank, which is a particular challenge I think within the acute sector, and how in some cases we bring down the overall hold times. Nevertheless, our commitment remains to delivering to the £60 million deficit to the year end, and we, in acknowledgement of those risks, are looking to the I&I process to really make a valuable contribution in terms of underwriting our ability to do that.
Thank you, Matthew. Clear, depressingly clear. So I think this board notes the risk in the numbers and the performance, but we also note, as you have alluded to, and Nick, that this I&I regime will help us really get to the bottom of what we're doing and add further grip and control. So I think it's fair to say we're not out of the woods yet, and there's still a lot of work to do. But we note the new risk that has come up in terms of prescribing that's come through the work to rule, I think, through primary care action. That's a new and emerging risk that we hadn't contemplated in that way previously. So we do note that. Can I ask, is there anything anyone would like to say? Anyone? Questions? Are we clear? Saki.
Saqib Ali, Audit Chair. Just wanted to check the 8 million on the SIP that's on a line SIP recovery that's nothing against it at the moment. That's a whole system one, isn't it, that we're trying to... Sorry, it's one that's unallocated at the moment. Is that right?
No, that is just on the ICB.
Yeah, but it hasn't got a program against it yet. Yeah, and then if you just do very simple maths of if we're 11.6 a month for, then that's 36 if you just roll it up, so that it's got a lot of backloaded delivery, hasn't it? Because otherwise that's a gap of 18 million on full year.
But at the same time, sorry, thank you, Hayden. Some of it not surprisingly, but at the same time, yes, you're right. I wouldn't necessarily attribute significant extra risk just because it's back-ended, because in some cases there are sort of binary things that it's impossible to say at this stage as to sort of phase them in a more appropriate way, and it's easier in a sense to regard it as a month 12, even if the development of that SIP might be progressive over time. But yes.
Thank you.
Tim.
Thank you, Sim. Tim Nolan, Non-Exec Director and Chair of the System Productivity Committee. For those online, that's the primary finance committee of the organisation. And as a result, I work quite closely with Matthew and his team on this. Just wanted to say, really, for the record, so to speak, the team are working very hard, first and foremost. The whole organisation is, but talking about the finance team. Secondly, I think they've been ably supported by the exec and also, very importantly, our partner organisations across the trusts. I think we've seen big progress in the last few months as the collaborative working, and it's difficult times for everybody, but I think that is improving. Still not perfect, but I think we're making good progress in that regard. So that's also very positive. I think Matthew's outlined well the challenges, and the numbers are still not where any of us would like them to be, but a lot of work is in place. And Saqib's also highlighted correctly that there's still significant risk in the numbers. Just the one thing I wanted to add really specifically is there's a lot of work ongoing with colleagues and NHS England in building together what we're calling a bridge back to the targets for the year. And I just want the board and the wider public to be aware that that work is ongoing. And within that bridge, that how do we get back to our plan, there's still some risk in that as well. It's not, to use a colloquialism, going to be anything like plain sailing. And there's a lot of challenges that will be laid at a lot of people's doors to get there. But I don't want people to think we're just blithely sitting by thinking we're trucking along and we'll get there. A lot of work being done, a long way to go, and risk still within it. But the work is happening in the background in all organisations, not just the ICB. So that was it. Thanks.
Thank you, Tim, for that assurance. I'm going to bring Steve in to close this item. Thank you, Steve.
Yeah, thank you, Chair. So Steve McManus, Chief Executive of Royal Berks and Foundation Trust and Trust Partner Member. Probably just to add to Matthew's summary, kind of a risk which I think is also held at the moment that is very present is the cash risk. So 3 of the organisations, the 3 acutes, have a material cash risk now. So the cash balance across the 3 is at month 4 sub 30 million. Given the turnover of those 3 organisations, that's significant. 1 is already receiving cash support. The other 2 are likely, as we go into either certainly back end of month 6 or month 7, to require some form of cash support. The risk is clearly about cash reserves to, make salary payments, which is clearly a priority, but also to keep up with our supplier payments as well. But the other risk for the system is that to protect cash, we may well have to start cutting back and reducing our capital programs. So that will mean that the capital opportunities in buildings, IT and equipment, both equipment replacement and new equipment, gets compromised because of having to protect the cash position. So I think it's a really material risk that is something that we should be flagging kind of as well, because it affects the system in a number of different ways.
Steve, thank you for bringing that up. Matthew, did you want to respond to that in any way, please?
I think there's a couple of things worth saying. Firstly, thank you for raising that. There are some things that the ICB can do to help, and I think those are being explored. I think the biggest uncertainty at the moment is how ERF is funded and how the deficits are funded. When we go back to the beginning of planning, there was an assumption that the money, that the overall system 60 million deficits would get funded much earlier than at present it has. And frankly, as of Friday last week, there still wasn't clearance from the Treasury to fund that. There remains an expectation, but not the commitment yet in terms of pressing a button and the funds flowing. So that, for all provider plans, will be or continue to be a significant risk. So underlining it, really.
But the ERF, receiving the income from the ERF, will go some way to alleviate the cash problem, the cash reserves. Marginal, okay.
Well, only in as much that all of our plans have an element of over delivery against the elective thresholds, which are baked into certainly the 3 Acutes core plans. So we need to deliver that level of elective activity to hit our plans as they currently stand. So I don't think there's anything above and beyond in terms of how necessarily ERF will add further benefit, but they are important to hit our plans.
Thank you, Steve, for explaining that relationship. Last word, please.
Yeah,
Nick.
just picking up Steve's point. So a couple of things. Firstly, I think it's important we make sure this is reflected on the board assurance framework if it's not explicitly stated as a risk. Secondly, the position of trust in the system does vary significantly, and some are relatively cash rich. And therefore, I think it's important we look at the art of the possible in terms of how we work as a system to support those trusts that are more challenged in terms of the cash they have in the bank. And I know we've had conversations along those lines, but perhaps we just need to look what more we can do. Yes, excellent. That was the right answer.
Yes, that's correct.
Splendid.
Excellent.
I don't want to qualify that.
Yeah,
we are trying, continue to try.
Yeah.
Thank you.
This is where mutual support sort of kicks in, if you like. I think that's what you're saying, Nick. Thank you. Okay. So, following that difficult section, let's move on to development and oversight. So we've got a little bit of decision, please, to make, and this is about the system constitution. So we've been mandated by NHS England to update and relook at our constitution, and Claire is going to take us through what those changes mean. And I thought the paper was very clear, so thank you, Claire.
Thank you, Chair. Claire Doble, Deputy Director of Governance. So this is item 13 in your pack, page 92. I'm going to take the paper as read, but in summary, as Sim said, we're bringing a revised constitution for recommendation of approval as a result of the model constitution amendments as directed by NHS England, and they published that on the 26th of July. Other iterations have been included as stated in section 3 of the report, and I've taken the liberty of seeking further assurance from our regional NHS England colleagues who have approved the iterations for presentation. I've put the iterations in highlight just for ease. So, and just to let you know as well, the document was presented for assurance to our Audit and Risk Committee on the 27th of August. No comments were received, and the committee recommended for approval to the board. So the board are therefore being asked to, 1, approve the changes to the ICB constitution as set out in the document, and 2, support an application to NHS England for variation of the constitution. Thank you, Chair.
Short and sweet. I'm hoping colleagues will have gone through each of the changes, which was so wonderfully highlighted by Claire, so very clear as to where to look. So is there any comment or any reflection on that paper? If there isn't, I'm going to ask for agreement then and approval for the changes that have been put forward, which seem sensible in some cases. So if there's no further comment, I'll take that paper and the changes as approved. Excellent, thank you, colleagues. And then the second portion is to support the application to NHS England for a variation on that constitution, which is a formality. Thank you, colleagues. Thank you, Claire. Thank you for putting the paper together and so ably highlighting the sections of change. So I think going ahead then, we've got some Board Assurance Committee updates. So this is where the non-exec directors who chair some of the board subcommittees will just give an update, having had our subcommittee meetings. Some meetings are not in the cycle, so haven't taken place yet, hence Aidan not presenting today. And the People Subcommittee Board only took place on the 10th of September, so they're not in the papers, but I can give a verbal update. So, colleagues, if I could just ask then Audit and Risk and Sakib as chair, just to give us the assurance we need, please.
Thank you. As you heard, we met on the 27th of August. The ICB Constitution was brought to us as we've just gone through. So on the alert, the single tender waivers. So this is where, outside of normal planning, you'd sign off a contract and you renew it for a period of time. A number of those have been coming to Audit and Risk for review, and so we can mitigate those in the future by better planning to avoid and reduce future use. To risk the primary care GP collective action has been mentioned in change management. There's a plan to meet the system audit chairs, and that planning is already in progress. And I think that's something that it will help align our various risks. And then to also mention the anti-crime progress, counterfraud was noted as green, and the digital toolkit, substantial assurance. One thing that I would highlight as the evolving patterns are in terms of finance and other issues, I think it's important that we regularly review our internal audit plans, that they evolve, and it's very important that we have horizon scanning to note what's around the corner, because I think that's where sometimes you can get frozen in, that's the plan, but I think we are in changing times. So that's my update. Thank you.
Thank you, Sakib. That sounds assuring that it's a sort of a live issue. Exactly. You'll be horizon scanning. Thank you. Margaret, may I ask, please, population health and patient safety?
Yeah, thank you, Chair. We met on the same day. It was a busy day. Just one issue to raise to board, and it's flagged in the alert section of the report. Throughout the course of committee, as we discussed each agenda item, whether it's primary care, cancer, obesity, weight management, every item we noted, obviously, the great pressures, and we noted the cost pressures, and potential slowdown in some services to meet the cost, the budgets and so on. So I think it was accumulation of all of the conversations where we saw that there'd been an underspend in dental, and we discussed the pressures on community dentistry. There's been an underspend in inequalities work, and that's all gone back into the pot to help with the deficit. There's pressures on SEND, and there's suggestions that service is slow, the improvements in that service is slowed. So the accumulation of all those conversations, each one on their own worrying, but taken together, the alert is to say, this is difficult this year, and there haven't been some drastic changes in service provision yet, but difficult decisions down the line. So the timescale and also the aggregation of those risks, that we haven't really stood back and said, what are the implications of the GP waiting lists, of the primary care pressures, of slowing down work on mental health, of the pressures on children and young people, mental health services. We haven't looked at that segue, how each responds to the other in time, over kind of longitudinal time. So we're looking at obviously very, very tight financial pressures this year, but the alert was to say that, you know, there's some difficult decisions coming down, excuse me, coming down the line, and that we will be aggregating those risks and looking at a holistic picture. Thanks.
Thank you, Margaret, for describing the challenge that is laid before us, and the way that you're looking at, you know, the potential impact now that the financial position has on our activity and the reality of that situation. That's pretty clear. Thank you for alerting the board to that. Just in terms of the people committee, so we specifically look at just ICB people, and our meeting was held on the 10th of September. What obviously occupies the people committee's mind is the change programme. That's where we seek assurance that the approach and the policies and the way that we've handled and communicated with our people is professional and as clear as can be. So we sought assurance on that. And then within that, looking ahead, how we work as a system and new ways of working. So we looked at hybrid working, and then with that brings health and safety issues in terms of re-looking at the health and safety policy to ensure that places where our people work, be that at home or in various places across the patch, are fit for purpose and safe. So we continue also to talk about organisational development and the plan to support people as they come through that change programme, and what things are in place and how we support those that are have been through a lot. So there's recognition that the teams in the ICB have been through a lot, and we need to support them in being comfortable moving forward so we can deliver on our plan. So that is people. And then Tim, is there anything else you want to add above and beyond what you said?
Yeah, a couple of things, that's okay. The report's in twice for some reason. I'm not sure it's that good and worthy of that, but there you go. I won't dwell on the financial position point. It's there. I've mentioned it already. It just mentioned the point that Steve quite rightly highlighted about cash. So I think that's already been brought to everyone's attention, that is a serious concern. The draft financial recovery plan, it's only a small part of this report. It's one bullet point, but this took over the vast majority of the meeting. It was a very in-depth 40-page, 39-slide deck that was submitted on behalf of the system to NHS England. So it's a very significant piece of paper or work. And it, as I said earlier, it does build that bridge back to the deficit of 60 million. But I just want the board to overtly be aware that it's a very, very challenging plan, and we're not for any means saying it's as I said earlier, it's not a walk in the park, and it's really important that everybody here understands that that bridge is a strong stretch, let's put it that way, and there was a lot of debate, a lot of challenge, and Alistair, who's online, was very helpful in expanding on the work that Matthew and the team are doing to explain how that can be done. But it's very important everyone in this room and beyond understands that. Just on the advice side, I think this is worth noting as well, the first point, it's not anything to be alerted about per se, but the System Recovery and Transformation Board, you may have seen it also appeared on Steve's slide earlier when talking about the Acute Provider Collaborative. And we haven't spoken about it a great deal at the board, but the view of our committee is that it is a very significant body, and for those of you that are not familiar with it, it has all the chief executives for the whole system on it, and some of the senior members, and it's potentially going to be very significant in the development of the system over the coming months and years, and as it's such a senior operational group of people, and at the moment it nominally does report to this board, I believe. It certainly doesn't report to our committee, although we're being updated on its work, and so the sense is that perhaps it does need, as a standing agenda item, even if it's just a 5-minute, 10-minute slot. I don't know if it would be Nick, probably would be Nick as the lead there, just to update the board more broadly as to what that committee is doing, and particularly the forward look, because the clue's in the name. It's about transformation, and we all passionately want to transform things for the residents here. And I think we need that board, we need to be confident and sure that that board is transforming in the right way for the good of the system. So that was important. And then there were just some more practical points about the operational metrics, making sure we're measuring against operational metrics rather than a long-term plan, which at present, you know, is a longer-term objective rather than this year. But no, it was a good session.
Thank you, Tim. Really useful. And I'm going to bring Nick in to talk about that transformation board.
Yeah, I think Tim raises a really important point. I think the action we need to take away on the back of this is that we need to ensure that there's a regular update to this board in relation to the System Recovery and Transformation Board, which is a monthly meeting. Actually, we're meeting on Friday this week, where we're going to dedicate a fair chunk of our time to carry out a sort of workshop looking at planning for next year and digesting a review of planning from last year that Hannah and colleagues undertook, interviewing a variety of key stakeholders, not least provider chief execs and CFOs, etc. So yes, I think we should include a regular update, probably as part of the Board Assurance Committee updates section. Thanks, Tim, for that.
Thank you, Nick, for that clarity. We have come to the end of our board meeting, so just a couple of things from me before we close. I think it's been a really interesting meeting in as much as I hope the board feel they are the risks are very visible in terms of our financial performance, and they are not going to go away, as Tim alluded to. But on the counter of that, you've got the work that we're doing, which we have to continue to deliver. When we talk about the APC or we talk about PLACE, these are the areas that really play into the ICB's remit. So I just want to thank all of the members of staff of the ICB, all of our partners around the system for their courage and resilience. This is challenging and it's hard and it's pointless to think otherwise. It is. So it takes a lot to be able to perform under these circumstances, and I just want to recognise those that are doing that, and Nick and his team as well. So I think it's very important to say that. And also, you know, to balance the risk with the potential. So this system has great potential. If we can just crack our financial performance and the way that we're structured, we have so much good to do and to offer this area and this geography. So I just wanted to say that. If there is no other business, I would like to close by thanking all of those people that have moved on from the ICB, colleagues I mentioned before, and just I want to give particular thanks to Rachel Deco again. A personal thank you from me. Rachel stood and stepped up when we were in between CEOs and has always been a presence here within the ICB since the time most of us started in May 2022. So her consistency, her resilience, her ability to lead her team, plus work clinically, plus take on the reins of CEO and required, have been invaluable to the system. She will be greatly missed, but I am so pleased she's not leaving the geography. So we look forward to be able to continue to work with you, Rachel, and support your new area of hospices, and something that we haven't really touched upon before. But again, just thank you from me and the board. Thank you, Rachel. So, colleagues, our next meeting is the 19th of November, 2024, and we'll be in Buckinghamshire for the next, it's just like question time, isn't it not? But thank you to everyone for coming today, and thank you, Wokingham, for welcoming us. Thank you.